السلام عليكم. النهارده نتكلم عن الحاله اللي اتفقنا معاكم عليها انا وفريده. الحاله دي هنستعملها حاله كأن احنا في امتحان، جايبين الحاله عشان نمتحن بيها زي الامريكان بورد، او رايحين نقدم على شغل في مكان. الحاله بتاعتنا ومفروض بيسالونا، او رايحين نقدم على بوست جراديويت بروجرام بتبين شغلنا وبتحصل منها الدسكشن. قولي لنا يا فريده بقى عندك ايه النهارده؟
دي حالة 19-year-old male راح لدكتور التقويم عشان كان عايز يعمل علاج تقويم، بس الدكتور لقى عنده كاريز فحولوه لدكتور السنان بتاعه الممارس العام عشان يعمل حشوات قبل ما يبتدي علاج التقويم. ما كانش في initial complaints من ال patient و non-contributory medical history. No, there was nothing interesting في medical history. فراح 19.
اوكي.
فراح للدكتور السنان بتاعه ولقى ان الثلاث سنان 27 و 36 و 37 محتاجين علاج اندو، فعمل لهم البالبكتومي وحوله لنا. we received these x-rays with the pulpectomies done.
يعني البيشنت ما كانش عنده symptoms؟
No.
Okay. And turns to be root canal. 3.
Yeah. So this x-ray لازم نتعود لما يبقى في x-ray قدامنا نقراها، ما نركزش بس على المشكلة، نشوفها نحللها كلها عشان لو في حاجة extra نقولها للعيان من الأول عشان ما يبقاش فيه مفاجآت ونعالجها ونحلها.
يعني شايفة ايه؟ قولي لنا.
في الاكس-رايز دول شايفة ال 8 ال 2 8 وال 3 8. ال upper ال 2 8 based on what I see ال path of eruption ممكن نقول إنه هو somewhat عادي، ممكن يبقى buccally inclined شوية. ال lower is impacted ال mesioangular impaction.
تخلقيهم؟
Just with these x-rays لا. I'd ask for a panoramic عشان أشوف المورفولوجي وال length of the roots وأشوف ال proximity وال relation مع ال inferior alveolar nerve canal عشان أحدد ال difficulty بتاع الكيس وهل إحنا محتاجين نشيله ولا الأفضل إن إحنا نخليهم، ونشوف clinically برضو هل المريض عنده symptoms في pericornitis is it partially erupted ولا لأ.
طيب ودي العيان ده هيعمل أرثو تشيليهم؟ هو هيعمل أرثو فعلا تخلعيهم؟
في literature في it's a debate. في ناس بتقول إنه الأحسن إن إحنا نخلعهم قبل ما نبتدي orthodontic treatment عشان بعد كده ما يحصلش they don't cause crowding. وفي ناس تانية بتقول on the other end إنه ما فيش correlation أو إن wisdom teeth per se are not the cause of crowding. فلو في orthodontist متابعينا or they're watching this وقروا عن الموضوع ده أو في عندهم حالات أو كده they can share their what they think and what they read في الكومنتس.
الأزهري. Okay. Okay, what else do you see?
What else? Okay, I see incipient interproximal caries بين ال 2-5 وال animal caries في ال 2-5 وال 2-6. عشان دايما بنحبذ وبنحاول ان احنا نبقى as conservative as we can be. I wouldn't treat this from the get-go. هشوف العيان، قلنا in this case ما عندوش symptoms بس we'd assess it ونشوف هو هنشوف هو is it active, it's not. In this case I would start with fluoride applications and try and promote يعني remineralization ونشوف كمان encourage the patient to practice good oral hygiene habits, the use of dental floss وبرضو نتابع الكيس and control it with bite-wing x-rays to see the lesion if it progresses or how it goes.
Okay, you told me that he did pulpectomy for the 2-7. I see clinically it's like I see the roof of the pulp chamber, isn't it?
I mean, I'd have to ask for a bite wing to see it better, like now. And yes, I see what you're talking about.
Okay. For this little guy, was it done? It was done, right?
Yes.
Okay.
But I just want to point that I think the trunk of the chamber is a bit long, and also the amount of peri-cervical dentin, the remaining tooth structure is compromised, but I don't have a preoperative x-ray. I don't know what this case was like and how the professional that did this was thinking. Maybe they were driven to
يعني تفتكر هو شلفة الضرس يعني شال منه زيادة؟
لا مش حاضر اقول شلفته ولا لا بس
Okay.
I guess I would I can't judge based on someone else's work if I didn't have the preoperative case, but
Okay.
maybe he was driven in this direction, you know, due to caries, and so he was forced. But
Okay.
I definitely have to warn the patient of like future risks when restoring this tooth, etc.
What's that pericervical dentin thing?
The amount like 4 millimeters اللي هما apical and coronal to the CEJ, cemento-animal junction.
Okay. Anything else you need to worry about in this case?
We can also see again the interproximal caries. وبرضو I point out the importance of checking the patient's occlusion. When it's not something we should neglect, especially in this case, the teeth, they're going to be heavily restored. They're in very poor condition and the amount of remaining tooth structure is minimal. So we want to protect what we have, and I guess I would consider occlusal reduction and check clinically if we have the marginal ridges or not, and the plunger cusps to prevent fracture and to, in general, just protect what we have left.
Would you do this now? At this
Before,
level?
and I'd start thinking about this at this phase, at this point, because I'd like to maintain the same working length to preserve the same reference point, I guess, throughout the treatment. Yes.
Okay.
To avoid repeating x-rays, etc.
Very good. Now, okay, so this patient, let's assume that he started with irreversible pulpitis. Would you do occlusal reduction here? Routinely?
I guess I probably would not routinely do occlusal reduction in cases of irreversible pulpitis, but in cases of sensibility or sensitivity on biting, I would consider. But
Percussion.
on pain on percussion, I would not say that I would routinely probably not associate the two.
Fine. That's another post that we will do, inshallah, about this issue. Fine. What else do you see?
In the 3-6, برضو I'd have to warn the patient إن ممكن يبقى في remaining caries أو still some caries that are left that I might have to get rid of, and this would further weaken the tooth even more and compromise the amount of peri-cervical dentin that's remaining. In this case, we might have to consider that we need a crown lengthening procedure or so to restore the tooth.
Okay, so let's talk about the 2-7 here.
Sorry to cut you off, but I also want to mention the horizontal bone loss pattern that I noticed. فبرضه ممكن نعمل يعني pocket probing depth to assess the patient from a periodontal point of view as well to control and eliminate that.
Okay. 2-7. Will you do this root canal?
Me?
Yeah.
I'd call you. Just based on this X-ray, I can't see the palatal or the distal buccal root. I can't see the outline of the roots, nor can I trace their canals. So I think that's something that's a challenge in itself. And also the roots appear to be pretty long. So
should that be elongation in the radiograph?
The crowns appear to be normal to me, so I would say no. I think the roots are considerably long. So this case for me would be a high difficulty case.
Okay, so you think the mesobuccal root is easy?
Can't help but notice the curvature of the root.
Yeah, the accessibility.
I'll leave that to you.
Yeah, accessibility here would be very hard. You can see the angle where you have to approach the canal. هتدخل ازاي، ولازم تعمل straight line access وتوسع. انت عندك rubber dam واكيد might have some limited oral opening. كل دي حاجات factors هتبقى you have to consider very carefully. ده root canal بعد ما خلص، مش انا اللي عامله طبعا، بس معمول very beautifully طبعا. Can you see the مش بكر root, the distal بكر root, the filling? Can you see it?
To the end? No, I don't.
So what would you need to do here?
Yeah, we repeat the X-ray بس نغير I guess the angulation horizontally.
So you're not repeating, you're taking another radiograph. This one is good one.
Taking another radiograph.
Okay.
But changing the angulation horizontally just so that we can separate the roots and see them better when we change it horizontally.
Okay. بسرعة خالص عن الروت كانال بتاع الحالة دي. الروتس طويلة، لازم الابروتش بتاعنا يبقى very careful لأن الهوم ورك بتاع الفايل كتير، هنمشي كتير جوه الكنالز، وعندنا accessibility. متخيل انت الفايل 25 length والهيد بتاع الهاند بيس. It's gonna be a challenge. obturation كمان لازم ابقى عارف which technique I'm going to use. الحالة دي probably عشان اعمل الوم vertical او lateral cold lateral spreader هيمشي كتير جوه او البلاجر. I might consider here the monocone technique, the hydraulic pressure bioceramic seal might be to make it easier in this case. The results are very good and I think we have a good chance of success here.
Inshallah.
Inshallah. Here we go. Now we have what's left بقى ال 2.6 ال 3.6 وال 3.7. We'll talk about them المرة الجاية إن شاء الله. احنا عندنا عملنا ال 3.7 ولسه ال 3.6 probably هنعمله sometime this week. ولما نخلص هنيجي نتكلم عليهم. شكرا.
I just want to say thank you, Baba. I just want to say for fresh graduates like myself or any students that are watching this that we should train ourselves to think globally and to look at X-rays as to pay attention to and read X-rays, get as much as we can and all the information that we can get from X-rays, and to always explain the treatment plan and put yourself in the shoes of the patient so that everything is clear from the very beginning and there are no surprises.
Cool. So you're summarizing your work. Well done. That's another good thing. أنا بالنسبة لي بقى آخر take home point عايز ألفت نظركم ليها. لما سألتها على الشغل اللي قبل كده she did not criticize الدكتور، قالت إن هي ما تقدرش تحكم على حاجة ما شافتهاش. But this is ethics as important as كل الكلام اللي احنا اتكلمناه ده. إن احنا ما نعيبش على شغل بعض، واحنا ما نقدرش نحكم الوضع كان ايه قبل كده، لأن احنا في بينا مريض مش عايزينه يصدق ده ولا ما يصدقش ده. Unless there is a pitfall أو there is an iatrogenic mistake. في الحالة دي مسؤولية اللي عمله إن يقول للبيشنت عشان ما يسيبش البيشنت حد تاني يقول له. مرة جاية نكمل. برافو فريدة.
Did I pass?
Yeah,
نجح؟
of course.
هتشغلني عندك يعني؟
You'll find out. Good luck everyone.
Bye guys.
Bye-bye.